Muito boa tarde, bom dia e boa noite.
Good afternoon to everyone. We have people watching from all over the world, and this is one of the great advantages we have from doing remote events. It's not easy, we all know, but the attempt to do a hybrid event was thought to start going back to normal life or to the new normal life little by little. So today we have the honor and the privilege of hosting our 11th international workshop, Diagnose the Test with ensured quality that are accessible for public health problems. For us, it is even a greater privilege knowing that we have so many people supporting us in this long journey, and especially with the support of top organizations. So I would like to thank USAID, NC Wellcome Trust, the London School, Chatham House, everyone who have been supporting LADIV in its initiatives. And of course, I also have to thank CBDL, the Brazilian Chamber for Laboratorial Diagnosis, the International Diagnostics Center, the Inter-American Regulatory Convergence Alliance, and AudiMed, which is the Alliance for Medical Devices for Latin America, for all their support. So for this opening session, we will hear the initial remarks from Daniel Vasquez from USAID, from Jessica Rope from NC, Scott Kiosi from Chatham House, and Rosanna Pearley from the London School. So thank you all for being with us. All the presentations are being recorded and will be made available within our education programs and in the work we do to foster regulatory convergence. So now I'd like to invite Mr. Daniel Vasquez to make his initial remarks and talk about the work of USAID in the project for regulatory convergence of medical devices. Jessica will also talk about that. Thank you very much. And Daniel, the floor is yours.
Thank you so much. I appreciate that introduction. I'm Daniel Vasquez, Senior Standard Specialist with USAID. It's a pleasure to join you today. And just talk a little bit about the work that we are doing jointly with ADVAMed and the Inter-American Coalition under the COVID-19 Medical Device Regulatory Convergence Project, also known as MDRC. Just to give a little bit of background of how this project came to life, as the pandemic was hitting and the US government was programming its support to help partner countries address the challenges of the pandemic, we very quickly, jointly talking with our industry partners, realized that donating medical devices and other goods that were needed to help countries effectively address the pandemic was not enough. There was a group of rules and regulations that needed to be also adjusted in order to effectively address the challenges that we were facing and that were preventing some of the products that were arriving to the market to arrive at the points of care and patients. So with that in mind, we work with ADVAMed and the Inter-American Coalition in designing the MDRC project, and that has allowed us to reach out very effectively, partner governments around the world to work and address some of the lack of convergence challenges that we have been identifying. I look forward to listening to the conversation today. Unfortunately, I won't be able to stay for the whole of it, but I'm sure that you will have a very successful program, and I wish you the best of luck in the presentations and the event as a whole. Thank you very much.
These initiatives. Jessica, would you like to take the floor?
Thank you, Carlos, and thank you, Daniel, and welcome everyone to today's international workshop again on this quality assured and accessible diagnostic tests. As noted, my name is Jessica Roop, and I represent the American National Standards Institute, which is a private nonprofit organization that administers and coordinates the U.S. voluntary standards and conformity assessment systems in the U.S. And it's my pleasure to be here with you today. As Daniel alluded to and touched on a little bit as well, I'm going to provide a little bit of additional background regarding the Standards Alliance Phase 2 program, specifically related to the MDRC. And as we're all aware, since the start of COVID-19 pandemic, nations across the world have really raced to increase production and access to medical devices to prevent and treat the deadly virus. And in-demand resources, including the rapid diagnostic test kits and PPE and ventilators, include all of those in-demand resources. However, countries cannot safely deploy these products without a really strong medical device and regulatory convergence framework and knowledge of emergency use authorization procedures and rules. So the Standards Alliance Phase 2 is a public-private partnership with the U.S. Agency for International Development and ANSI, which among other priorities focuses on COVID-19 response and recovery. In particular, the SA2 COVID-19 MDRC, or Medical Device Regulatory Convergence Project, is focusing specifically on reducing barriers to countries' importation of US medical devices that aid in the fight against the COVID-19. MDRC is a partnership, again, between ANSI and USAID, and it's spearheaded specifically by the Advanced Medical Technology Association, or AdvaMed, and they are an ANSI member as well. So the MDRC serves to increase transparency and predictability of partner government countries' regulatory ecosystems for medical devices. It aims at aligning them with international standards and improving overall national quality infrastructure. So ultimately, the collaborative effort will enable the importation of the test kits, improve government's acceptance of these international standards for medical equipment, and diminish regulatory barriers and impediments. And lastly, train various agencies and private sector on documentation that is really required for regulatory approval and the proper use of medical device testing and equipment. So we are in our third year of implementation of this program, and we're making great progress. And the topics that you all be addressing today throughout this two-day workshop will contribute to the overall MDRC achievement of the various objectives. So in advance, I'd like to say thank you to you all for your support and your effort to make this event a success. And I'd like to thank you again for your attention. And I'll defer to Carlos and the moderator to continue the opening remarks for this valuable two-day session. And thank you so much.
Thanks a lot, Jessica. It's really a great pleasure to have you here and explaining a little bit of what we have been doing. This journey is not so short, it's a long journey, and we do have a lot still to accomplish. And to bring access as an easy thing, or access to new qualities that can change a person's life, is really essential. And for that, in the ADAP, which is the Acceleration Access to Diagnostic project, I would like to invite Scott Giossi from Wellcome Trust to give his initial speech. Scott?
Hello everyone. So yeah, my name is Scott. I work at the Global Health Program at Chatham House. So I'll be quite brief. I just wanted to thank everyone for attending this event on behalf of Chatham House. And Chatham House is the Global Health Program specifically, aims at trying to accelerate progress, facilitate, conversation, and also strengthen global health security. And we think that through the ADA project, we can try and achieve these goals. And yeah, we look forward to hearing from the attendees, and I hope that we achieve a fruitful discussion. And that also will, together with the workshop that we had in Cameroon a couple of days ago, and also with the one that will be held in Asia next year, that these conversations will help build on the global event that will happen in 2022, and also develop an impactful policy brief at the end of this project. And just a few words on the Cameroon event. It was also very fruitful. We had also simulations that allowed to have quite in-depth discussions. So we actually reached 10 key points to act on, and also looked at solutions for these barriers, and also looked on what are the next steps after this workshop. And I'm sure Rosanna will also tell you more about it, both at the ADAPT and the Cameroon event after me, I think, and during this event. And that's all from my side. Thank you all again.
Fantastic. Thanks a lot, Scott. And I would like now to bring the person behind all these connections. Actually, the one that is making this constellation of stars really show and shine and actually go to the same direction in order to promote access to those who need the most. Rosanna Peeling, would you take the floor, please?
Hello, Carlos. Thank you very much. And indeed, it's my pleasure to be here to welcome everyone to the 11th workshop that we have co-sponsored together with all our different partners in our mission to increase access and accelerate access to quality assured diagnostics. As we all know, the world of diagnostics has been constantly changing with our changing global health security issues, global health priorities. Different diseases require different types of diagnostics and how they should be used in different settings. And so the COVID-19 for us had many teachable moments, and required now new thinking about how diagnostics should be done and should be used. And there were new technologies that had been developed during the pandemic. And so I just like to say that it would be impossible for us to do anything about the advance of diagnostics without all of you as partners in this long mission to increase and accelerate diagnostics for quality, to advance the quality to assure diagnostics to achieve good outcomes for all. And so with that, I'd like to bring you welcome from the London School and the International Diagnostics Center. And on behalf of Dr. David Heyman, who unfortunately had scheduled conflicts and could not be with us today, but he will join as soon as possible. Thank you.
Thank you, Rosanna. It's really a great opportunity for us to share experience, not only throughout Latin America, which is going to be most of the event, but with colleagues from other regions and other countries as well. Last week, it was held in this ADAPT program, another similar event in Cameroon. Rosanna is going to bring a little bit more details, but it's just to show that it's a global effort towards improving access. We have different needs, but that can be accomplished with the same products most of the times. So now we are going to start the seminars, and the first speech is going to be about introduction to the consultation of accelerating access to diagnostics, when Rosanna is going to show exactly a little bit of more detail on this program and how it's actually been working and what is the next step for us. Rosanna?
Thank you, Carlos.
20 minutes.
Okay, thank you, Carlos. What I'd like to do now is to do a short introduction to this consultation today. And I'll start with some slides on the need for new thinking about diagnostic access. And then in particular, in the second part, I will talk about this Wellcome Trust funded project to accelerate diagnostic access, ADAPT. Now, as we all know, for a long time, diagnostics are useful in patient diagnosis and management, so that the correct care could be given, the correct treatment could be given. It's also critical in surveillance and disease detection, at least for infectious diseases, that alerts us to when there are outbreaks and unusual happenings. And then testing allowed us to confirm what is the reason for the cause of the outbreak, and also the containment, and including contact tracing on other public health interventions that could be triggered from a positive or negative diagnostic result. And of course, it's useful for epidemiologic research and clinical trials for both drugs and diagnostics. Now, with the pandemic, we have now looked at how diagnostics could be used in non-healthcare sectors, such as in mass gatherings, in schools. So that's a new use of diagnostics. And how could we be optimizing the test characteristics for that remains to be seen. There's also a big global health crisis that have been worsened because of the pandemic, and that's the antimicrobial resistance global crisis. And so diagnostics has a critical role to play in the precision use of anti-infective drugs, because if we lose these drugs, then all of modern medicine cannot be the same as before. And perhaps we will go back to the pre-antibiotic era when even minor infections can kill a person. Now, first about the pandemic. We all know that pandemic or epidemics used to happen only periodically, maybe, a big epidemic once about every 10 years. But since the last flu pandemic in 2009, we've seen a continuous occurrence of outbreaks that are occurring with more frequency and more severity. And so we really need to strengthen our access to diagnostics in order to confirm clinical diagnosis, to screen for asymptomatic infections within communities, to try and interrupt the chain of transmission, and then to use diagnostics, especially antibody tests, to estimate the true extent of the outbreak, the geographic hotspots, and also monitor the effective interventions. Now, as I mentioned before, antimicrobial resistance is a program that has been really adversely affected by the pandemic and lockdowns. Now, in 2016, Lord Jim O'Neill issued a report to say that if we don't do anything about antimicrobial resistance, by the year 2050, 10 million people would die from resistant infections instead of the current 700,000. The cost in terms of global loss in productivity would amount to about $100 trillion US dollars, and 28 million more people would likely be pushed into poverty. And there we need to, again, try harder to look at the use of diagnostics to guide patient management and the appropriate use of antimicrobials, especially for syndromes like respiratory infections, for which a lot of them are caused by viruses and not by bacteria, but yet a lot of patients are prescribed antibiotics for these infections. Secondly, we need to be able to use diagnostics to screen for resistant bacteria, especially in health facilities, in order to prevent its spread throughout the institution to affect the vulnerable people. We had reports from countries that, in fact, a lot of COVID patients, when they go into hospital, because of the long stay, they acquire resistant infections, so that even when they got over COVID, they die from these resistant infections instead. So finally, we want diagnostics to conduct surveillance so that we know what are the trends and to be able to assess the impact of interventions. Now, how has the COVID pandemic affected AMR? A study that was conducted in 88 countries showed that there was a gross overuse of antibiotics for COVID patients. About 72% of hospitalized patients receive antibiotics when only about 8% demonstrated bacterial or fungal co-infection. There's been increase in healthcare-associated infections within hospitals because more people have been admitted to hospital, especially for long term. And then because of lockdowns, there's been major disruptions to health and vaccination services, and that increased the risk of infection and use of antimicrobials. Now, we all know now that we use diagnostics, we use tests as a diagnostic tool in the pandemic to confirm clinical diagnosis in symptomatic patients, to do contact tracing, and also to do case finding in hospitals and care homes and in first responders, so that they are not acquiring infections for those they care for, nor transmitting them to other people who are vulnerable. But we now also have diagnostics as a public health tool. We have tests to protect the vulnerable situations. Like if you go into hospital or care homes, you need to test negative in order not to spread infection in case you are one of the asymptomatic spreaders. We can use tests to release people from quarantine when they're in quarantine because they're positive or because of travel. And then finally, but not the least, is the test to enable the reopening of schools, workplaces, and mass gatherings and travel so that we could, the economy could recover. These tests use are also being supplemented by the fact that in some countries, home testing has been approved for use so that people can test themselves at home or with a healthy telehealth proctor. Now, when we use the test to enable, that's a new use of diagnostics. What are the required test performance characteristics? This is something that it's not something that regulators alone would know how to do that. In fact, it would require regulators and policymakers to come together to consider the test sensitivity and specificity that's needed. And don't forget that testing is only one of several layered interventions to reduce the risk of transmission in these events. There's also wearing a face mask, physical distancing, hand hygiene and cough etiquette, and also ventilation when it's an indoor event. Now, testing could have, the lack of appropriate testing could have major economic consequences. And I want to show you this example of what happened in Kenya. In May 2020, the government of Kenya decided that truck drivers are a high-risk group and that they must show a negative molecular test in order to leave port, to drive to different throughout the country, as well as to different countries in Africa with their goods. And because the results for molecular tests take up to 2 weeks to get back to the truck drivers, within a very short time, there was a 90-kilometer traffic jam at the port of Mombasa, where trucks were lined up with drivers waiting for their test results. All of the trade has been halted because of this. And because truck drivers are congregating there, there's also a risk of transmission amongst themselves during that location. It was a very desperate situation. And fortunately, in July, the International Organization for Migration provided more rapid PCR tests to the truck drivers across Kenya as part of an effort to reinvigorate the regional economies in South and Central and East and Central Africa. So they made the test results available within 24 to 36 hours, and they tested 17,000 people and from July to October. And you could see that, having the right test at the right time for the right patient group or people would really make an important contribution. And it's not only test sensitivity or specificity, but time to result is really important. Now, what are the lessons learned from this pandemic? There are new considerations that we need to think about. When we try to balance, I always say the 3 A's of accuracy, access, and affordability. Now we need to add the time to result as a one key component, depending on the circumstance of where testing is done. And so the risk of false positives and negatives that regulators regularly consider now should be, added by the risk of considering the lack of access, especially to marginalized populations, because they will continue the spread of infection if they don't have access. So we haven't got a handle on control of diseases, or if the test had a long turnaround time. So those are the new things that we need to think about in terms of risk. And then for incremental benefit, it's not only to the patients themselves, but to society as a whole, which means that with the consultations for policy, we need to be thinking about other partners in this consideration of diagnostic access. And then the second point is that throughout the pandemic, there's been a lot of technological innovation. This convergence of digitization, diagnostic technology, and information technology has allowed us to look at dashboards like this that I'm showing from the Johns Hopkins website. Daily, they post how many cases there are around the world, deaths, and now even vaccination by country as well as by region. And so we could see from firsthand that there's a real advantage to make better use of the convergence of these technologies to allow data to be turned into real-time intelligence in order to inform public health interventions and control strategies. Finally, policy development, as I mentioned before, needs to be more inclusive of other partners such as civil societies, departments of finance, education, trade, tourism, and in country and across countries. Now, we were very fortunate in 2019 and early 2020 to be funded by the Wellcome Trust in a project called Accelerating Diagnostic Access, ADAPT. And that's because we long recognized that the pathway to from bench to bedside is actually fragmented with many duplications that are unnecessary, duplications of clinical performance studies. There are blocks and there are gaps along the pathway that really impede the development, evaluation, regulatory approval, policy development, and implementation of diagnostics that we need. And so the length and the current complexity of this pathway substantially increase the development costs, so that the final cost of goods is much higher than they need to be. And that in turn reduce the impact that the test could have on patient outcomes and disease control, including epidemic response and antimicrobial resistance. So you could see from this figure that regulatory approval including clinical performance studies can take as long as 3 to 5 years. And then policy development and adoption, including procurement distribution, could take 5 to 7 years. So we want to make sure that we have means of accelerating this pathway, but without compromising in quality. And one of the initiatives of WHO and other partners have been to use emergency use listing or authorization. And so countries can actually try to follow that process so that they don't have to duplicate a lot of the clinical performance studies. And I think we'll talk more about these later. So the objectives of this project are to conduct stakeholder mapping to better understand the regulatory licensing and development of policy pathways for point-of-care diagnostics within key countries in Africa, Asia, and Latin America. And we focus on point-of-care tests because they are tests that can be done at the point of care or point of need, and therefore are more accessible by their nature to begin with. So that's a good starting point. Second objective is we like to increase awareness amongst all the stakeholders such as regulators, clinicians, public health experts, and policymakers on the bottlenecks and the fragmentation and duplication in the current pathway, and then identify possible solutions to overcome these barriers that impede the rapid and timely licensing and introduction to use of point-of-care diagnostics. And then based on the outcomes of all these consultations and mapping, we will then develop policy briefs for a regulatory policy framework to accelerate licensing and introduction to use of new quality assured point-of-care tests. And so this is the timeline for our project, and it's been delayed because of the COVID pandemic, but we are now starting the regional consultations, and the Asian one, as you heard, the Cameroon one was for Africa was last week, and the Asian one will take place early next year. We already had an industry consultation in February of 2020 before the lockdowns, and so it was up to us in the first quarter of next year to consolidate all the findings and plan a high-level meeting in London early March of next year in order to consider the framework for acceleration. And we welcome our partners in this project with Africa CDC as our focal point in Africa, Aladif as our focal point in Latin America, and ASEAN as our focal point in Asia. And so now for our consultation here, our objectives are to understand the need for accelerating and increasing access in this region, and to be able to brainstorm on the options for accelerating access with new technologies and new environments, and to be able to agree on options to move forward. So with that, I thank you very much, and back to you, Carlos.
Thank you, Rosana.
Obrigado, Rosana. Essa é uma excelente forma para entendermos o que está acontecendo com o nosso projeto. E para que possamos ver quais são os gargalos que precisamos aqui no Brasil. A Rosana com a Aladiv, nós fizemos uma consulta piloto com resultados excelentes. E uma das ferramentas que geralmente utilizamos é uma ferramenta de simulação. essas simulações
shoes of somebody else is actually to think differently and see the same problem that sometimes it's invisible. So we are now going to show to you the preparation for a simulation exercise and one kind of example. Thanks to our colleagues from Peru, they did 3 different examples with different exercises. We're going to show one after this initial video, just a short idea. And that's what we are going to do in the countries, because the best is really to have in-person exercise of the simulation in order to understand the key points and what we can actually do all together to overcome. Alguns pontos agora em termos de...
Now talking about some attention points. Please, if you wish to ask questions, make sure you send them via chat or through the Q&A functionality. Second message is we have simultaneous translation for Spanish and English and Portuguese. On the bottom portion of your screen, you'll find an icon called Interpretation, and you can select your preferred language through there. So having said that, I would like to thank Rosana for presenting her talk. And now I will invite you to watch a video that talks about the impact that we have had in education and in other fronts during the pandemic. And after that, I will show a simulation that was conducted in Peru. The video, please. There's no audio in the video.
Yeah, and this is one of the most thorny problems, most difficult problems, I think, with COVID-19, because and for the reasons that I think are very obvious to everybody, which is that first of all, everybody has different levels of risk tolerance. And by everybody, I mean different societies. We see, for example, the regions of the world, like the Special Administrative Region in Hong Kong and in New Zealand, and places where people are striving to have zero COVID, and you have very little tolerance as a society for it. And then you have other countries, like many parts of the United States, that are essentially saying, we're willing to live with this, and it's not a problem. So there's a societal risk tolerance issue. And then there's an individual risk tolerance issue. We have a huge problem in New York City that many of the populations that benefit most from, free, widely available public school system are from communities of people who tend to be very poor and disadvantaged. And they don't trust that their school will actually keep their children safe. So we also have individual trust issues about the schools. And so even if we say we're willing to tolerate infections, many individual families will say, no, they don't trust that because their grandmother is sick and they live at home with them. And so therefore they will simply not go to school. And that gets to the third issue, which is that we don't have a good way of measuring the harm from children not being in school itself. And so this becomes a very imbalanced risk calculation, because we're very easy to quantify the number of infections or hospitalizations from COVID-19 that occur in a school community. But you cannot add up very quickly and accurately the loss of education.
One of the major challenges when we were affected by the COVID that was last year was how can we respond to the COVID-19 with 3 different and specific missions. The first one, of course, was to control the spread of the virus. The second one, to limit the mortality due to the COVID-19. And last but not the least, to limit the socio-economic impact of this disease. To limit the spread, we decided to invest significantly on testing. And by testing, initially we meant molecular testing, as it has been suggested and supported by the World Health Organization. So in a short time, we were able to have 14 molecular labs in 9 of the 10 regions in Cameroon, which was already something great. However, we quickly realized that was not enough because we have delayed to receive the result. It was starting from 1 week, sometimes 2 weeks. And within that time, you cannot, one, take care of your patient, and two, you cannot control the spread of the virus. So we decided as a country, one, to evaluate the rapid test, and two, based on the result, to implement them. And we did that successfully to the extent that 6 patients confirmed positive out of 10 in Cameroon were confirmed by a rapid test based on our national algorithm.
It is unfortunate, I think, that PCR and antigen have been sort of characterized as one is good and one is bad. And to the extent that I think, unfortunately, antigen testing has in some people's minds been thought of as something wholly inaccurate and very second rate. Actually, antigen testing has the new antigen test, for instance, have a specificity that is the ability to correctly identify a negative test as good as PCR, which is often what we want because we want to know people are disease-free. And of course, that real difference in aviation, for instance, in travel, we want disease-free people. We're sticking them in a metal tube together. There's an increased risk of transmission there. So antigen tests are actually as good as the nucleic acid amplification test, the PCR tests, for an awful lot of purposes. PCR has a completely different set of advantages. It takes longer. It will often be done with multiple probes into different parts of the virus genome, and so can often give us some interesting characterization. It can also give us an idea of the viral load, so it can tell us something about what part of disease processes people are in, and will usually preserve the specimen that's used so that we can put it into a formal genetic sequencing test. So they're very different. They take different times. They both have very, very good specificities. That's the ability to correctly detect negatives. There's a bit of a difference in the sensitivity, but much of the sensitivity of testing depends upon how good a sample you get to start with. If you don't get a good sample, the test's going to be rubbish, whatever you do. But above all, the time difference. If you want to rely on a negative test, the ability of that negative test to hold good declines over time after the test is taken. So using an antigen-based test done as close to the point of travel as possible gives the best assurance that people are in actual fact not infected and not infectious during the travel period than a test that is done, say, 2, 3, 4 days beforehand, which will then have very, very limited reliability. So, the thing is, they're both excellent tools. You need to know what the characteristics of performance are, and you've got to pick the one that's suitable for the job that you need doing. And remember, the job that you need doing might be, has somebody been infected, but equally, is somebody not infected? Those are two important outcomes.
Bom, peço desculpas pelo...
I apologize for the technical mistake. The video will be made available together with the rest of the presentation, but I hope you are able to get an idea of what we are talking about. Every time we do an activity like this, every time we do a public consultation, basically we try to identify the existing problems that today could act as a barrier for the arrival of new products, and what do we actually need to do? This exercise is done with different stakeholders that are part of the public health discussion. Regulators, policymakers for the health sector, the industry, patient groups, labs, and other stakeholders. Because the need is to raise awareness among all of them that in reality we have a common goal. Our goal is to provide access to quality products that will make a difference. After all, an early and accurate diagnosis can lead to a more effective treatment, and that became very clear during the pandemic. To talk about one of these barriers, actually a standard that was created and that ended up generating a lot of problems that we didn't predict, I would like to invite you to watch a second video to show you what is the impact that lives suffer because of a decision like this. This was done in a simulation, by the way.
Take care. Okay, take care of yourself. Take care too. Bye. So you've seen that. That's a simulation and it looks like a joke, but this problem with the borders is more severe than we think. Due to the Omicron variant, we've seen what happened with the borders last week. So do we have different tools? Was that really necessary? This is some of the topics that we have to discuss. Today, we already have tools that can make a difference. I understand that today with COVID and the PCR and the antigen tests and everything else, we already have a broad range of options.
Bom, vocês fiquem também à vontade até para trazer.
Well, just to let you know, please send us questions if you have through our chat box or the Q&A functionality. I don't think Rosanna